Shock, a critical condition where tissue perfusion drops and organs begin to fail. There are 4 types of shock, each with its own cause, presentation, and treatment: hypovolemic, septic, cardiogenic, and neurogenic. First, let's define what shock is. Shock is defined as a state of cellular and tissue hypoxia due to reduced oxygen delivery, increased oxygen consumption, or inadequate oxygen utilization. The result? Organ dysfunction, metabolic acidosis, and eventually death if untreated. Common signs include hypotension, tachycardia, altered mental status, cold, clammy skin, except distributive shock, and oliguria. But different causes leads to different types, and treatment must be tailored accordingly. So, hypovolemic shock. Perfect example, trauma patient after an MVC with a blood pressure of 80/40, heart rate of 130, and a pale skin. Hypovolemic shock is all about volume loss, whether it's blood through hemorrhage or plasma through burns, vomiting, or diarrhea. There's not enough circulating fluid to perfuse the tissues. The pathophysiology will then result in a decreased preload and a decreased stroke volume, resulting in a decreased cardiac output. Compensatory tachycardia occurs, followed by vasoconstriction. Typical causes include trauma and hemorrhage, GI losses, and third spacing in cases such as pancreatitis or burns. What are the clinical clues? Cool extremities, a narrow pulse pressure, flat neck veins, and a positive response to fluids. Treatment. Well, make sure you have 2 large IV bore axes, crystalloids first, then bloods unless the patient's actively bleeding significantly. Control bleeding ASAP, and you may need massive transfusion if you've lost a lot. Let's go to the next one, which is septic shock. Elderly patient with pneumonia with blood pressure of 85/55, a heart rate of 120, febrile, and warm skin. Septic shock is a type of distributive shock caused by infection. The infection occurs and it leads to immune activation and cytokine storm, which then leads to vasodilation and capillary leak, leading to a decreased systemic vascular resistance and hypotension. Initially, it has a high cardiac output, but still inadequate to cause perfusion. Clues: warm extremities early on, unlike other shocks. There's going to be some fever, tachycardia, a wide pulse pressure, a lactate more than 2 millimoles per liter. This may progress to cold extremities in late stages. Treatment: think sepsis 6. Oxygen, blood cultures, broad spectrum antibiotics within 1 hour, IV fluids, which is going to be at least 30 ml per kilogram of crystalloids, measure and trend the lactate, vasopressors if your MAPS is less than 65, and the first line would be epinephrine. The most important thing when you're actually treating someone with septic shock is understanding if you need some form of source control, which is very important for surgeons. Next one, cardiogenic shock. How does this present? Middle-aged man with MI having cold sweats, a blood pressure of 90/50, with jugular venous distension because of heart failure and RALS from all the backup of fluid. Cardiogenic shock is a pump failure. What happens is there's a decrease in contractility, leading to a decrease in stroke volume and a decrease in cardiac output. The compensation initially occurs with increased systemic vascular resistance that actually worsens your afterload. Causes: acute heart attack or MI, arrhythmias, valve rupture or dysfunction, and cardiomyopathy. Signs: jugular venous distension, pulmonary edema, cool clammy skin, narrow pulse pressures, and crackling on lung exam. These are mostly signs of heart failure. Treatment: these include inotropes to improve contractility, vasopressors as needed. To improve blood flow within the heart, you may need either a PCI, which is a stent, or revascularization procedures through a bypass. Diuretics if you have pulmonary edema to manage your heart failure symptoms. And also, don't forget, avoid excessive fluids because it worsens the situation. Last type of shock, neurogenic. How does this present? Well, imagine a patient after a spinal cord injury with a blood pressure of 80/40. With a heart rate of 60, they're not tachycardic, and warm, dry skin. Neurogenic shock is the add one out. Why does it occur? There is a loss of sympathetic tone and unopposed parasympathetic activity. There is overall a decreased systemic vascular resistance, so your blood pressure goes down, and also bradycardia. Blood pools in the peripheral vessels. Common cause: spinal cord injury above T6, and can also occur in spinal anesthesia. The clinical picture includes bradycardia and hypotension. You have warm, dry skin and no compensatory tachycardia. What are the management? Support the airway and breathing, number 1. Number 2, IV fluids with caution. Vasopressors such as norepinephrine. Atropine for bradycardia. And you may consider steroids in spinal cord trauma. If you guys found the video helpful, please click the like and subscribe button. And please type your comments, questions in the chat. And I hope you guys check out the other videos for more learning opportunities. And I'll see you guys next time.